Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to be doing an NCLEX review over acute kidney injury, also known as acute renal failure. And this video is part of an NCLEX review series over the renal system. And don't forget to check out at the end of this YouTube video the quiz that will test you on acute kidney injury. So let's get started. So what is this condition? It is where there is a sudden decrease in renal function. So it comes on quickly and the kidneys aren't able to filter the blood like it should. And because of this, you get buildup of waste in the blood like BUN and creatinine, which are waste products from muscle breakdown and protein breakdown. You also will see fluid buildup in the patient because, again, those kidneys cannot remove that excessive fluid from the blood, and electrolyte imbalances. Now, acute kidney injury can be reversible if it's caught early and the cause is treated appropriately. So what exactly can cause acute kidney injury? Well, we have three different causes based on the location where it's located in the body. The first type of cause that we're going to talk about are the prerenal causes. And for NCLEX and your nursing lecture exams, be familiar with the causes that can cause this and where it tends to be located, before the kidney, inside the kidney, or after the kidney, because that's where a lot of test questions like to come. So prerenal. Prerenal, just like the name says, it's before the kidney. So any problem that's really arising from the renal artery upward to the heart. So your heart and your kidneys work hand in hand together. What your heart does is it takes the blood and it oxygenates it through the lungs and it goes back to the heart, and then it pumps it out through the body. And that fresh blood will go down through the heart, through the descending aorta, and then go into the kidneys through the renal artery and branch off into all these arterioles and go and feed to the nephrons of the kidneys. And remember, each kidney has millions of nephrons, and those nephrons are responsible for filtering the blood and reabsorbing nutrients and then creating urine filtrate, which is voided out through the bladder, through the urethra. So it all works together like this beautiful process. However, if you get a perfusion issue, this can decrease the function of the kidneys. So you have decreased perfusion, which is going to decrease the function of the kidney. Now, what happens is that there's a decreased amount of blood going to the kidney to be filtered. And the kidney is being deprived of nutrients, so it's not able to work like it should. And eventually, this can actually lead to intrarenal injury, where those nephrons inside the kidney become damaged and they quit filtering like they should. So what exactly can lead to a prerenal injury, causing that decreased perfusion? Okay, one thing is a cardiac issue. And what can happen is if there's damage to the heart muscle, it's not able to contract properly. These ventricles become weak. They cannot pump that blood down through that descending aorta, so you get decreased cardiac output, which is going to decrease the perfusion to the kidney. What kind of conditions can cause this? Well, one thing is a myocardial infarction. The patient has a heart attack, and part of that ventricle has died, maybe a large part of it, because of ischemia to the muscle. It was irreversible, and so that heart muscle is just weak and it cannot pump. Get decreased cardiac output. Another thing is bleeding. If you get massive internal or external bleeding, there will be decreased blood volume going to that kidney, not perfusing it. Dehydration with excessive diarrhea, vomiting, the patient becomes hypovolemic. And another thing are burns, which again is depleting the system of fluids. Then there are intrarenal causes, and this is where there is damage to the nephrons. So the problem is within the kidney itself. So if you took the kidney and you sliced it in half, you could find where these millions of nephrons are located. And if you drew out a nephron and stretched it out, it would look something similar like this. You would have the following structures, and the nephron can really be divided into two areas based on what they do. You have the renal corpuscle, which is your filtering structure, and that includes your glomerulus and Bowman's capsule. Then you have the renal tubule, which includes your proximal convoluted tubule, loop of Henle, distal convoluted tubule, then your collecting tubule and collecting ducts. And this is really where the renal system is going to remove excessive water or put more water back into the bloodstream and really tweak those electrolytes based on what you need. So it's really maintaining homeostasis in the body. Then whatever you don't need, you're going to void it out. And each nephron sets within the kidney, but the top part of the nephron sets in the renal cortex, and the bottom part of the nephron, specifically the loop of Henle and part of the collecting tubule / duct, sets in the renal medulla. And that's why whenever you look at the kidney structure, you see those striations on the renal pyramid. It's because of the bottom part of the nephron giving it that appearance. So if you have a problem with your nephron, what's going to happen? You're going to have a decreased ability to filter the blood, which is going to lead to excessive waste building up into the system. It can't remove it. You're going to have excessive water building up, and it's not going to be able to maintain electrolyte levels where they need to be. So what can cause intrarenal injury? Well, one thing is nephrotoxic drugs that are really hard on the kidneys. And this includes drugs like NSAIDs, antibiotics, specifically the aminoglycoside family, chemotherapy drugs, or contrast dye, like the dyes that patients receive for certain testing. Another thing is infection, and we talked about this in our glomerulonephritis video, which is one of the causes. If it's not treated appropriately and they have a really severe case, they can enter into this condition. And injury to the kidney. And lastly, there are postrenal causes, and this is where you can have blockage in the urinary system after the kidneys that can even extend all the way to the urethra. And what this will cause is it will prevent the urine from draining out of the system. So you'll get buildup of pressure in the kidneys from where all that urine is just staying in there and backflowing to the kidneys, and you have all this waste that isn't leaving the kidneys. So this can decrease the kidney function. So for instance, say that you have a renal calculi. That can be a cause. It's obstructing urine flow. And remember, it can be anywhere from the ureters to the bladder to the urethra. So another cause could be an enlarged prostate. Prostate in men, it can squeeze that urethra closed, so they have problem in emptying the bladder, and it can cause backflow of urine. And then things that cause a brain injury, a neurodamage, where like a stroke, where the bladder does not empty like it should, so they get the retention of urine, it can backflow and cause acute kidney injury. So before we look at the stages of acute kidney injury, let's cover the basics about the kidney and look at the labs that are ordered by the physician to determine if this is renal failure. Because whenever we're going through the stages or nursing interventions and the signs and symptoms, it's going to make sense why you are seeing an increased BUN and creatinine or a decreased GFR, and it'll help you understand that material a little bit better. Okay, so basics about the kidney. Okay, it's important to know how much an adult should be voiding normally. They should be voiding 1 to 2 liters per day, because depending on the stage, like if they're in the oliguric stage of acute kidney injury, they will be voiding usually less than 400 milliliters of urine. So you'll want to be watching out for that, because they should be voiding at least 1 to 2. Now, if they're voiding more than 2, like 3 to 4, maybe 5 or 6 liters of fluid, they could be in the diaeresis stage. Now, what does urine consist of? Substances really our body doesn't need. So you're going to be finding water in there, ions that will range from sodium to chloride to calcium, phosphate, bicarb, everything like that, because remember, our nephron pick and chose what we needed to maintain that homeostasis in our body, along with waste products, because we do not want that to build up in our body, like urea. Urea is measured in the BUN level, the blood urea nitrogen level, and this is a waste product from protein breakdown in the liver. And then we have creatinine, which is a waste product from muscle breakdown. And we want to maintain a fine balance of this, and a normal creatinine level is 0.6 to 1.20 milligrams per deciliter. So let's talk a little bit about creatinine, because now we're getting into our labs. So creatinine is measured a lot whenever renal failure is suspected, because they will take your creatinine level, your creatinine clearance, and your glomerular filtration rate along with the BUN to really determine how well those kidneys are filtering and removing waste from the body. So creatinine is solely filtered from the blood via that glomerulus. So blood's going through the glomerulus, creatinine's dripping down in there. Now normally, other substances that go through there like water and sodium, potassium will go through the renal tubule, and parts of the sodium and water are going to be reabsorbed back into the system, and what we don't need will void it out. Well, with creatinine, it's not going to be reabsorbed or secreted in the nephron. It is solely just filtered out, which is why creatinine is a great measurement to help us determine the ability of how the kidney is filtering. So we can measure how much creatinine is in the blood. And if we have too much creatinine in the blood, we know that we have decreased functioning of our kidney, which is why we can also look at what is called the creatinine clearance level. And this is the amount of blood the kidneys make per minute that should be free of creatinine. And the varies differ based on gender. So for females, the normal range is 85 to 125 milliliters per minute. That is the amount of blood that woman should be producing through the kidneys that should not contain creatinine. And for males, it'll be 95 to 140 milliliters per minute. Now, you can use the creatinine clearance values along with the patient's age, gender, weight, race to determine what is known as the glomerular filtration rate, the GFR. And what is the GFR? The GFR is the rate of blood flow through the kidneys. So it tells us how well the glomerulus is filtering the blood, because that's that main structure in that nephron that is doing that job. So a normal GFR should be 90 milliliters per minute or higher. And again, it takes all these other things like the age, the gender, the weight, and the race into consideration when calculating this estimation. So let's take a little quiz. If our GFR is decreased, our glomerulus is not filtering that proper amount of blood, what's going to happen in our body? What are we going to see in our patient? Okay, what is their urinary output going to do when you have a decreased GFR? Are they going to be putting out a lot of urine, or is it going to decrease? Their urinary output is going to decrease. They may experience oliguria, less than 400 milliliters per day of urine. And that urine is going to become concentrated because that glomerulus is not filtering the amount of blood it should. It's decreased. What is going to happen to the water in the body? It is going to increase because the glomerulus is not removing the right amount of water, so it's going to stay in the blood. What's going to happen when we have too much water in the blood? We're going to get some hypertension, edema, swelling. Now, what will happen to the waste in the blood, specifically the BUN and creatinine levels? They're going to really increase as well. So your patient's going to start experiencing azotemia, which is the buildup of waste in the blood, and they can enter into metabolic acidosis, acidotic conditions, because they are not excreting those hydrogen ions like they should, and you have decreased bicarbs. So we're going to get that. And then another thing, what do you think is going to happen to your electrolytes? They're going to be all over the board. Specifically, you're going to see high potassium levels like hyperkalemia. Phosphate levels can be high, and their calcium levels can be low, among those other types of electrolytes. So anytime if you get to have clinicals on a renal floor or you're working on a renal floor, always look at those labs before the patient is scheduled for dialysis, because dialysis is one of those treatments for this condition. And you will notice that before they go for dialysis, the patient's blood pressure is going to be super high. They're going to have swelling. You're going to go look at their labs. They'll have an increased BUN and creatinine. Their potassium level will be sky high. And they will have in their Foley, if they have a Foley, usually they do, their urine will be really, really dark, and they'll just be like a very small amount in the Foley bag. And then after they go to dialysis, their blood pressure usually is better, and whenever you draw labs, morning labs, those levels will be down because it's replaced the job of what your nephron should have done in the first place, that dialysis machine. Okay, so now let's look at BUN. What was BUN? That was measuring that urea level. It's blood urea nitrogen level. A normal level for this should be 6 to 20 milligrams per deciliter. And again, urea is the breakdown of protein in the liver. So liver breaks down the protein, secretes it into the blood because it knows whenever it does this that the kidneys are going to take it and filter it out. However, if the kidneys aren't working properly, it's not going to be able to remove that urea. So you'll have high levels of BUN greater than 20 in this condition. And also something that can increase BUN levels are conditions like that cause dehydration. Now let's go over the stages of acute kidney injury. And as I do that, make sure you pay attention to the name of each stage, how they occur, and the signs and symptoms that present in each stage, along with the nursing intervention that goes along with that sign and symptom. Because that is where test questions like to come from whenever you are studying this condition. Okay, so the first stage is called the initiation stage. And just as the name tells you, this is when it starts. So it starts whenever there is something causing that kidney to become injured, either prerenal, postrenal, or intrarenal cause. And it ends when the signs and symptoms start to appear, which can occur a few hours to several days. And this is really when you want to find out the cause and treat that cause to prevent long-term damage to those nephrons, because if it's not corrected soon enough, they can enter into chronic renal failure, which is what we will be talking about in the next video. Okay, now after the initiation phase, patients can go into what's called the auxiliary phase. Now, it's important to note that some patients will actually skip this stage and enter into the next stage, the diaeresis stage. So you may have a patient who has renal failure, the beginning stages of it, but they have massive amount of urinary output and they're not putting out a low amount of urine that you would expect. So they may have skipped this stage and went to the next stage. Okay, so the auxiliary is where you will notice that your patient's urinary output is going to be less than 400 milliliters per day. And why? Why is the urinary output so decreased? Well, remember, it's because the glomerulus has decreased in its function to filter the blood. So when you look at the labs, they're going to have a decreased GFR. Okay, so let's look at the signs and the symptoms. Because they have a decreased GFR, they're going to have an increased BUN and creatinine, that waste level. Azotemia. So your patient is probably going to have some neurostatus changes. They're going to be confused, really sluggish and tired and sleeping all the time. And they can also itch from where that waste has built up and it causes itching on the skin. Nursing interventions for that, you want to watch their protein consumption, so limit that. Because remember, the breakdown of protein in the liver increases urea levels, so you want to limit that. And their safety, because they're going to be confused, may not know where they're at, they can get up and fall, things like that. Another thing is hyperkalemia. And this is because there's a decreased excretion of potassium in those kidneys. And what can happen whenever you have a high potassium level, you have to watch out for cardiac issues. They can have a significant cardiac event. So you got to watch the EKG and look for tall and peaked T waves, wide QRS complexes, and prolonged PR intervals. That can represent hyperkalemia. So your nursing interventions would include restricting potassium-rich foods. We don't want to give them any more potassium. They have enough. Monitor their EKG. They need to be on a bedside monitor to watch that. Assessing labs. The physician may order a medication called K-Exolate, either orally or rectally, and this will help bring down that potassium level, so be familiar with that. Another thing is they will have increased fluid in the body because the glomerulus is not removing that excessive water. So you can see swelling throughout in their face, around the eyes, and their legs, so edema. Because of that, they are at risk for pulmonary issues from where all that extra fluid is going to go into the lungs, cause breathing issues. They can have cardiac issues from that, hypertension from the increased blood volume. So nursing interventions would include limiting their fluid intake, monitoring their intake and output very strictly. We want to know exactly what they're taking in and exactly what they're putting out. Daily weights, get them up every morning, use the same scale and weigh them, because weighing a patient is a great indicator of how much water they are retaining. And then as a nurse, you want to look at the weights. Okay, today's weight, they were 200. Yesterday, they were 190, so they've gained 10 pounds. That's very significant. Monitor their blood pressure because they're going to have hypertension, assessing those lung sounds for crackles, which would represent pulmonary edema, monitoring their oxygen saturation, looking at that swelling going on. Is it decreasing or is it getting worse? Okay, next they can go through what's called metabolic acidosis, and this is because you have decreased excretion of those hydrogen ions, so you're getting very acidic blood, and their blood pH could be less than 7.35, and they may present with confusion with that, along because they have an increased BUN and creatinine level 2, and they may be doing a type of breathing called cosmal breathing, and this is a deep, rapid breathing, and it's your body's way of trying to compensate to increase that blood pH because it's very acidic. So carbon dioxide is an acid, so your body is causing them to breathe deeply and rapidly to blow off that carbon dioxide out of the system, hoping to increase the blood pH. So you may see that. So what you want to do nursing intervention wise is monitor their safety because of confusion and their respiratory status as well. And patients can also present with mild hyponatremia. So a low salt level, it'll be very mild or it could be normal. It could be, the reason for this is because the blood is diluted from the extra fluid that's in the blood, so that level can run low. Also, they may have an increased phosphate level and a decreased calcium level, because remember, phosphate and calcium are opposites. If one's high, the other one's low, or vice versa. So you'll want to restrict their phosphate foods and monitor that. And another thing they can have is that really concentrated urine. So if they produce any urine really at all, it'll be really dark and concentrated, and it'll have a high urine-specific gravity, and that will be any value greater than 1.020. Now, how long does this stage tend to last? It tends to last a week to 2 weeks, and you want this stage to be as short as possible, because the longer the stage is, the longer and more of an increased chance that there's going to be damage to those nephrons, and again they can enter into end-stage renal disease, chronic renal failure. And the treatment for this stage is dialysis. Our next stage is called the diaeresis stage, and this is where our nephrons are on their way to recovery, but they're not 100% yet, but they're getting there. So now they have the ability to actually filter the blood, so they can start bringing down our waste levels, that BUN and creatinine, getting that out. However, they can't concentrate the urine yet, so we're not really going to get some electrolyte balance, and our water levels are still going to be crazy. Now, the GFR is improving, but it's still abnormal, so that's why you're seeing the decrease in the BUN and creatinine. But those levels will still be abnormal, but your patient will start to become more alert and oriented compared to how they were in the previous stage, the oliguric. Now, your patient is going to be voiding a massive amount of urine, about 3 to 6 liters per day. And why is this? This is due to what's called osmotic diuresis. Okay, so remember, the kidneys can filter the blood now. Now it has a lot of waste to filter out. So what's going to be in that filtrate? A lot of urea. So that newly created filtrate is jam-packed full of urea. This is going to cause osmotic diuresis. It's going to pull a lot of water out. They're going to be voiding 3 to 6 liters per day. Now because of that, use nursing knowledge, because we're voiding so much fluid out, what's going to happen to our fluid status in our body? In the previous stage, we were fluid overloaded. Now we are fluid depleted. So we're going to become hypovolemic. We're at risk for dehydration, hypotension. What's going to happen to our electrolytes? Well, before we were struggling with hyperkalemia. Now we're voiding so much out, we're going to be wasting potassium. So we're going to have hypokalemia. And how's our urine going to be? It's going to be really diluted. So they'll have less than 1.020 urine-specific gravity. The urine's going to be really diluted. So nursing intervention-wise, what we want to do is we want to maintain strict I's and O's because they're going to be losing a lot of fluid, those daily weights, signs and symptoms of dehydration, and the physician may be ordering supplements to replace those electrolytes that are low because they're being voided out. And they may be on IV fluids, which seems like a paradox for someone who's in renal failure. But if they're in this stage, they need it so they don't go into dehydration. Now this stage can last anywhere from a week to 3 weeks. Okay, so after they go through this stage, they hit the last stage called recovery. And this starts when the GFR returns to normal. Now, let's ask ourselves, what is going to happen with our urinary output since our GFR has returned to normal? We're going to be normal. So 1 to 2 liters is what they should be putting out per day. What's going to happen to our BUN and creatinine? It's going to become normal. It's going to stabilize. And our electrolytes are going to be normal where they need to be. So everything will be maintained. And that's how we know that we are in the recovery stage. Now this stage can take a year or more depending on the amount of damage that was done, how long they spent in the aughluric stage, and the patient's age. So it's different for every patient. Now some patients unfortunately never make it to the recovery stage because there's just too much damage, and instead they develop what's called chronic kidney disease, end-stage renal failure, which we will be talking about in the next lecture. So this wraps up this lecture on acute kidney injury. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.